The results we presented are the results of a phase 2 multi-center international trial evaluating olutasidenib as a single agent in relapsed refractory AML patients. So this is a cohort, the results of cohort 1, in which 153 patients with relapsed refractory AML received olutasidenib alone at the dose of 150 milligrams BID over continuous 28-day cycles. And the primary endpoint was characterization of CR and CRh. So altogether, 123 patients were evaluable for efficacy. 72% have discontinued, mainly due to disease progression, roughly 1/3, few to AEs or death. So, as expected, the population was mainly represented by de novo AML, roughly 2/3 and 1/3 of secondary AML, including almost 80% post-MDS. Most had intermediate risk cytogenetics and as commutations we saw NPM1 first with DNMT3A and others. So overall response were achieved in 46% of these patients, which is fairly high. Composite CR rate, including CR, CRh, CRi, of 45%. 33% achieved CR, CRh, and importantly, true CR happened in 30% of the patients. So these results are probably very good, especially the high CR rates in that widely treated population. They received a median of at least 2 lines of treatment. Before discussing optimization, I must insist in the fact that these responses were durable. Responses were sustained for a median of 11.7 months in responders, and remarkably, so the median duration of responses in CR, CRh was not reached, and in a sensitivity analysis with stem cell transplant as the end of a response indicates the median duration of CR, CRh to be roughly 14 months. So that's very important. These responses are durable. So this translates into a very favorable overall survival with estimated 18-month overall survival of 87% in CR/CRh patients, which is fairly high. So this is interesting because the inhibitor seems to be very potent to ensure high response rates and durable responses. So the combination with 5-ASA has already been presented 2 years ago at ASH in the phase 1 part of the trial, and it's very well tolerated. We haven't seen any addition of toxicity with the inhibitor combined with 5-ASA, so it's clearly feasible. In the phase 2, there are some arms combining the treatment 5-ASA and olutasidenib, so it's feasible. We are waiting for combination with intensive chemotherapy. It's likely that it will be the same development as with ivosidenib.